Hello, I'm Robert Schmidt. I'm a medical director at ARUP Laboratories. Today I'd like to talk to you about testing a test. And we'll look beyond simple measures like sensitivity and specificity and look at evaluating test performance and maybe some ways that will be new to you. So the objectives here are to learn how to calculate basic accuracy statistics, number one, to understand reasons for differences that we might see in diagnostic accuracy tests. They behave differently in different circumstances. And to understand the difference between tests that are conducted under ideal conditions versus real conditions, which would be a reason why we might see differences in test performance, and then understand the role of high-level approaches for performance evaluation. So we'll cover all of these different topics today. I don't have anything to disclose relative to this discussion, so we'll proceed. So tests are central to medicine. They're used in many different ways, as you see here. Diagnosis is the most prominent one, but also used for prognosis, monitoring, and patient management. And so these are ubiquitous throughout medicine, so testing is very important. So tests exert a great deal of leverage. About only 3% of medical costs are represented by lab tests, but they control many, many decisions. I think the estimates are something on the order of 70% of medical decisions are made as a result of laboratory tests. So you can sort of think of lab tests as the tail that wags the dog. So it's quite important to understand their performance, and that's why we're going through this today. So let me look here at what I call the hierarchy of effectiveness. And so this is sort of like a tower where each layer depends on the ones beneath it. So in order to have good clinical performance, you have to have analytical performance. In order to have clinical effectiveness, you have to have clinical performance, and so on. So let me explain what each one of these things means. So analytical performance just means measurement of an analyte. So precision, linearity, those kinds of things that we're all familiar with in the laboratory. I'm not going to talk about that today. So clinical performance, the next thing, is our ability to discriminate between patients using the test as diseased or not diseased. And in order to do that, you have to have a reliable test. You have to have good analytical performance. So, but just because you can measure something doesn't mean that it helps you tell sick people from well people or disease from non-disease. So similarly, even though we can discriminate patients into diseased and non-diseased, that doesn't mean that it has clinical effectiveness. So, for example, we may be able to tell that somebody is ill, but we may not have a cure or something we can do for them, or the test doesn't really affect outcomes in any way. So even though we can discriminate between the well and the unwell, it really doesn't affect outcomes. And then finally, even though we can affect outcomes, it might be too expensive to be cost effective, and so on. So we're going to use this hierarchy as we go through this and look at evaluation of test performances at each of these different levels, except for the analytical one. So we'll just focus here on these three middle ones that are highlighted in yellow, and we'll talk about accuracy of tests in terms of discriminating patients, with the usefulness of tests, comparing tests, and all the other factors I've listed there. So as we go along, we'll use a case to sort of motivate some of the discussion here. So let's just imagine that your father has just returned for his annual physical, and his doctor suggested that he consider a prostatic-specific antigen test to screen for prostate cancer. So he knows you work in a laboratory and know all about evaluating tests, and he's unsure what to do, and he asks your advice. So should he take the test? Well, let's look at we'll use that example as we go through. So the basic task for any test is classification, right? We want to discriminate or differentiate between those people that have disease and not disease. So here we have on the bottom of this graph some sort of test result. I don't know what the units are, but you could have a score of 5 or up to 35. People with disease tend to have higher scores, somewhere in the 25 to 30 range, and people with no disease tend to have lower scores, somewhere between 7 and 15 or something like that. And we have a cutoff for this test of 18, which nicely divides the groups into diseased and non-diseased patients. So this is sort of a perfect world where the test can easily discriminate between these two groups. So what we do usually is tabulate in a 2x2 matrix test performance. So here we have on the left side of the matrix people who test positive with the test and the number that test negative. And then on the top we have the true state of the world, whether disease is actually present or not. And here in this perfect test, we don't make any errors at all. When disease is present, we never say that it's negative, the test is never negative, and when the disease is absent, the test is never positive. But real life is not like this. So here's a not so perfect test. In real life, there's going to be overlap between the diseased group and the non-diseased group. So in the upper part there, you see the red dots are the people that have disease, and their distribution tends to be a little bit higher. Their test values tend to be a little bit higher than the blue ones, which are below and that don't have disease. So anywhere we draw the line, we're going to make some mistakes, and those are shown here. Okay. And once in our matrix up there is showing that. So the first group here are the people that have disease and the test is positive. So those are our true positives. The next group over is people that have disease but tested negative, and those are errors, and those are our false negatives. Then the next group is the ones that have no disease and the test is negative, so that's a correct result. So those are the true negatives. And then finally, there's people that don't have disease where the test result was positive, and so those are false positives. And you can see now that up in the matrix, it's different than it was before. With the accounting is shown there, and we have 52 false negatives, 40 false positives, and so on. So you can see this kind of accounting is nice, but it's not a good way to summarize really the performance of a test. Because let's say we had 1 million cases, we might have, I don't know, 4,000 false positives and 5,000 false negatives. And if we had 100 patients, we might have 4 false positives and 5 false negatives. So the absolute values of those aren't that helpful. So we usually discuss these in terms of ratios. So we look at this and go, how well did we classify people that actually had disease? So we can see out of 200 of those kinds of patients that we got 148 of those cases right, so that's about 74%. Okay, and that's the sensitivity of the test. So that's the accuracy of the test among people that truly have disease. And we do a similar thing for people that don't have disease. Okay, we had 200 of those as well, and you can see that there the ratio of the correct ones, of the true negatives to 200, is 80%. So specificity is a measure of accuracy among the population that does not have disease. Okay, so that's just summarized here. So sensitivity is a measure of accuracy in the diseased group. Specificity is a measure of accuracy in the non-diseased group. 2 useful mnemonics that were developed by Guyot and Sackett are SNOUT and SPIN. So SNOUT says a high sensitivity test with a negative result can be used to rule out disease. Similarly, SPIN says a highly specific test with a positive result can rule disease in. And so we can use this a little bit. Let's go back to our PSA test. So the sensitivity of the PSA test is 90% and the specificity is 20%. And so how might this test be useful using our SNOUT and SPIN mnemonics? Well, obviously this has high sensitivity, so we can use this to rule out prostate cancer, but a positive result really doesn't mean very much, right? That's quite poor. So if you have a negative result, you can feel pretty sure that you don't have disease. If you have a positive result, it doesn't mean that you have prostate cancer. Okay. So results for these tests may vary. So here's the sensitivity of the PSA test, and this is summarized here for a bunch of different studies. Each one of these dots represents the results of a published study, and the little whiskers on the side of the boxes represent the uncertainty in their estimates. You can see that they're typically around 90%, sort of like we said, if we were to average all of these. So one of the questions that arises is, how can this be? Why do people get different results like this? I mean, how hard can it be to do a PSA test? Why aren't they getting the same results? Okay. The specificity is even worse. Okay, we see a lot of variability there. And like we said, it was about 20% on average, but there's quite a bit of scatter around here. And once again, that raises the question of why are these different studies getting different results when they're using the same test? Okay, so the first thing that is a possibility to explain this is cutoff values. So let's imagine that we have a cutoff A, and we see a sensitivity of 74% and a specificity of 80%. Then we move the cutoff to another value, and these can change quite dramatically. So why is that? Well, let's look here. Here's an example. So here's the first one. Let's say that the cutoff that we use for these two groups is about 18 for this. And so we're going to capture most of the people that when disease is present, it'll score positive to the right-hand side of the cutoff. We're going to make some mistakes. There's some red dots to the left of the cutoff value. Similarly, for the people without disease, there's a sprinkling of people that are false positives that fall to the right of the cutoff value, but the bulk of them are to the left. So this test is pretty sensitive, but not very specific. We're getting quite a few false positives here. What happens if we move this threshold for the test? Let's move it up here. It becomes less sensitive, right? Because more people that have disease are to the left of the cutoff value, but it's much more specific. There's very few people that don't have disease that are to the right of the value. So you can see that sensitivity and specificity are not an intrinsic property of a test. It's not like, I was born with brown eyes and I'm going to have brown eyes forever. A test isn't like that. It depends on, it's a design property of a test of where the threshold is placed, and different people may use different thresholds, and therefore you'll see different values of sensitivity and specificity. So that's all summarized here, depending on where we move these. Okay, so in general, we're going to see a trade-off, as it was illustrated in those graphs, between specificity and sensitivity. So here we see 3 different thresholds, 3 different values for sensitivity and specificity, and this illustrates the general thing that you'll see is a trade-off between them. So how can we compare tests if that's a problem? Well, here's a way we can do it. We could look at all different possible specificities, and then for each test, list the corresponding sensitivity. So here we're kind of taking away the threshold effect by looking at all thresholds, and we can see that test A has a higher sensitivity than test B for every level of specificity. So it looks like test A is going to be more accurate, and that's correct. So this is one way we can do that. Well, it's sort of hard to look at a table like this and get that information. So one way we do this is by graphing these results, and we graph the true positive rate, or the sensitivity, against the false positive rate. So there's sort of a trade-off. You can be too trigger happy and pick up all the diseased patients, but you'll get a lot of false positives. Or else you can be too conservative and have no false positives and fail to pick up people that truly do have disease. But these two curves now show the trade-off between sensitivity and specificity, and it really clearly shows that test A has more sensitivity at any level of specificity than test B. So this is called a receiver operating characteristic curve. You may have heard that term. Some people refer to them as ROC curves or ROC curves, things of that nature. That's a good way to summarize and compare two tests because it eliminates the problem of the threshold effect. So let's just look at this a little more closely. What would an ROC curve for a perfect test look like? Well, it would have 100% sensitivity for every level of specificity. So that's shown here. It's a little bit approximate there in the northwest corner. But what it's trying to show is that you'd have 100% perfect sensitivity for every level of specificity. So there's no trade-off for the perfect test. Well, what would a useless test look like? Well, that's shown by the green line here. And that's as if the test was a coin flip. And, heads you have disease, tails you're fine. And basically that's what the ROC curve would look like for a test that was governed by a coin flip. So the one in the middle there, the dotted black line, is a typical test. They're somewhere between perfect and useless most of the time. So we want things to be more like a perfect test than a useless test. So the closer we are to the northwest corner, the better off we are. So, in general, the increasing diagnostic accuracy is when the ROC curve heads up to the northwest corner. Okay, so let's look at this. So that we can see that the area under the curve is related to diagnostic accuracy. So a perfect test that goes from 0 to 1 on the y-axis and 0 to 1 on the x-axis, so the horizontal axis. So the area under the curve of a perfect test is 1.0. For a useless test, it's just half of that, right? Because we're going across the diagonal, so it's going to be 0.5, and a real test will be somewhere in the middle, like 0.8 or 0.9 or something like that. So this area under the curve can be used as a measure of accuracy to compare two tests. So does this mean anything? I mean, I could tell you, oh, this test has an AUC of 0.8. Is that helpful to you? Can you interpret that in any way? It is when you do a comparison. You go, this test has an AUC of 0.9 and the other one has an AUC of 0.8. But by itself, does that mean anything? So one way to interpret this is that the AUC is the average sensitivity of the test over all levels of specificity. So you can look at the perfect test, and we know that the AUC for that is 1. So we're averaging the sensitivity over the whole range of specificity. It's always 1, so the average is 1. For the useless test, the sensitivity ranges from 0 to 1 as the specificity goes from 0 to 1. So the average of that will be 0.5. So that's the average sensitivity for a useless test. And a perfect test will have an average sensitivity somewhere in between. Another way to look at it is that the AUC is the probability that a test result from a diseased person will be greater than a test result from a non-diseased person. So let's just imagine that I picked one dot from the red group there. I put a blindfold on and picked a red dot, and then I put a blindfold on and picked a blue dot. And I looked at their two test values. And this says, what's the probability that the red dot had a higher test score than a blue dot? And obviously, the higher that probability, the further apart those two groups are going to be. It's a measure of our ability to discriminate between the two groups. So let's look here. When there's no possibility to discriminate, these two populations are virtually identical. If I picked a red dot at random and a blue dot at random, sort of a 50-50 chance that the red dot would have a higher score than the blue dot. And in this case, our test isn't very good. We can't discriminate between the two populations at all. And correspondingly, the area under the curve is 0.5, which is saying there's the probability of being able to detect a difference is basically a coin flip. So let's look at another test. There's the PSA, which we've been discussing, and then there's a thing called the PSA velocity. And the PSA velocity is measuring the PSA over time and looking at the rate it's increasing. And here we're looking at the area under the curve, which again we just mentioned before is a measure of diagnostic accuracy. And we can use that to compare two tests and eliminate the threshold problem. So the PSA velocity from these three different studies, here the one by Eggener, Sciatto, and Berger, it's always higher for the PSA velocity. So we can say that the PSA velocity test is more accurate for discriminating people with prostate cancer than the PSA test is. So there's an example of the use of the area under the curve. So the take-home message here is that with sensitivity and specificity, we have threshold effects. And we have to be able to compare tests. We have to ensure that people have used the same threshold. With ROC curves and looking at the area under the curve, these go away. We've eliminated that. And so it makes it a very good way to compare tests and get rid of this threshold problem. So now we've sort of looked at whether a test is accurate, and I want to explore another question. Just because it's accurate, does that mean it's useful? And let's look at that and try and relate these two concepts. Okay, so now I have a test here. It has an area under the curve of 0.8, which is probably pretty good. We want to go, is this test going to be useful to anybody? So what do we mean by useful? Okay, so our client, the physician, has a problem to solve. And they're asking, will this test tell me whether my patient has prostate cancer or not? And so the usefulness of the test is going to be defined by our customer by its ability to resolve that question for them. Okay? So you can imagine us lab people going, the AUC is 0.75. That's not going to mean anything to our physician. So they need to know how this can be used to help resolve a problem for them. So the problem that the doctor faces is they're under a state of relative uncertainty. They're trying to make a diagnosis, and they're uncertain about the diagnosis, or else they wouldn't order the test. And the test will move them from a state of uncertainty to relative certainty. You're never going to be perfectly certain, but to a point where they feel comfortable enough to make a diagnosis. And that depends on the customer. Some people are comfortable with different thresholds of certainty. Some person might need to be 99% certain. Somebody else 95% certain. There's no real guideline or benchmark that it's an individual sort of preference of risk, I think. But the general sort of problem here is that a test needs to be able to accomplish this task of moving from uncertainty to certainty. So the usefulness, the way I like to think about it, is a test's capabilities to resolve uncertainty relative to the requirements. So the doctor is looking at the uncertainty they have. They want to get to a certain state of certainty, and can the test bridge that gap? And a test, if it can, would be useful. So let's think a little more closely about how to think about certainty. And I'm going to use the odds scale here, not because I particularly like it. It's related to probability, but it makes some of the math we're going to talk about a lot easier. So the odds is the probability that somebody has disease over the probability that they don't have disease. And so we look at the scale over there. If you were completely uncertain about whether somebody had disease or not, you would be looking at odds of 1 to 1. So it would be like a coin flip. It would be equally probable that they have disease or not disease. Now, either end of this spectrum, you have a relative certainty, right? So at the top, in 1 to 10, it means you think the odds are very low that the person has disease. So that's a state of relative certainty. The other one, the other direction, of 10 to 1, you're going, it's highly likely this person has disease. So that's a relative state of certainty. So when we're doing a test, we're usually starting out someplace near the middle, and we're trying to move to either end. So if we go to the top, we can send them home. If they're at the bottom of the scale there with a high probability, we can initiate treatment or something like that. Okay. So one way I like to think about the capability of a test is its ability to change the certainty. So let's look at the odds of disease before the test. Let's imagine here that there's close to a complete uncertainty, that there's a 1 to 1 odds of having disease or not having disease. And then we take the test, and I like to think of this as the impact of the test is its ability to change this odds of disease. So here we're moving to a much more certain state, closer to 10 to 1. So the test is having quite a bit of impact on the doctor's knowledge about the state of the patient. So what is the impact of a positive result? We describe this by the positive likelihood ratio. And the positive likelihood ratio is the probability that you'll get a positive test given that somebody has disease over the probability that they would get a positive result given that they don't have disease. And those are the two shaded areas shown there. So we can see for the people that have disease, there's quite a good probability that they would have a positive test result if they have disease, and a very low probability that they'd have a positive test result. There's very few dots to the right of the threshold there. So very low probability of having a positive result given that they don't have disease. So the likelihood ratio here is very high. It's about 10. So in terms of a positive likelihood ratio, bigger is better because it will move you to a state of higher certainty. There's also a thing called a negative likelihood ratio. So if you have a negative result, we can apply this. So the probability of a negative result, given that you have no disease, with the probability of a negative result, given that you don't have disease. And that's shown here. So in the upper one, we have quite a few people to the left that would have a negative result given that they're diseased, but almost everybody that doesn't have disease is to the left of the threshold. So that makes it below 1, and for a negative likelihood ratio, smaller is better. So the key relationship that we look at here is we have some prior odds. We've done investigations, we've done a history and physical, we may have done some other tests, and now we have some odds that the patient has disease. Then we do another test. If it's positive, we multiply it by the positive likelihood ratio, and that gives us a new odds called the posterior odds. So that a test result changes our thinking about the probability or the odds that somebody has disease. And you just play this game over and over again of going from prior odds to posterior odds to a new test. The posterior odds become the prior odds, and you just keep leapfrogging like that and increasing your certainty one direction or the other. So let's look at this. So here we have somebody that's maybe a little more than 1-to-1 chance of having disease as their prior odds. We apply this test, which has a likelihood ratio of about 10. So we multiply the prior odds times the likelihood ratio and get the posterior odds. And we can see that we've moved, as a result of the test information, we've revised the odds that we had about them having disease, and it's gone from nearly complete uncertainty to nearly complete certainty. Okay? So as we mentioned before, there's two ways to be certain. One is you can exclude disease or confirm disease. So we do it through this equation of the prior odds times the likelihood ratio gives the posterior odds. So a test can solve the doctor's problem if the actual likelihood ratio is greater than the required likelihood ratio. So let's say the doctor says, I will treat this patient if the posterior odds are greater than 10 and my prior odds are 2. Well, then the positive likelihood ratio has to be at least 5 to be able to confirm disease, to the point where the doctor would go ahead with treatment. On the other hand, you might say that if we're trying to exclude disease, might have to say that the posterior odds are 1 to 10 and my prior odds are maybe 1 to 1, then the likelihood ratio would have to be less than 0.1 to be able to reach that a conclusion to exclude disease in that particular patient. So we might have a futile test where the required likelihood ratio isn't good enough. So here's the doctor going, I have a slight hunch that this person may have prostate cancer. I will do a biopsy if the odds favoring disease are around 10 to 1. So let's say it says his slight hunch is an odds ratio of 2. That's not a very strong. I think it's twice as likely that the patient has it than not, but it's probably not enough to send them for biopsy. And he does gives them a PSA test, and the positive likelihood ratio for that is very poor. It's 1.2. So is that going to help this doctor solve the problem? So gives the test, gets a positive result. The posterior odds then would be 1.2 times 2, or 2.4. The doctor says he wouldn't take any action until the odds were 10 to unless the odds were 10 to 1 in favor of disease. This is a futile exercise because this test isn't good enough to get him to 10 to 1. Okay, we can look at this on the ROC curve that I mentioned before. So it turns out that the positive likelihood ratio is just the slope of this line here. So it's the sensitivity over 1 minus the specificity. So the rise over the run given there. And so the shaded area is the zone with high likelihood ratios, positive likelihood ratios. And so the area where we have a likelihood ratio greater than 5, where the slope is greater than 5, is shown there in green. We might call that the rule-in zone or the confirmation zone. So that's the area where we have a very high positive likelihood ratio and we're able to rule in the test, and the test is good enough to solve somebody's problem. And we can think of this as sort of a customer requirement, that unless the test can perform in that zone, it's not going to be helpful to the customer. Similarly, we can create a rule-out zone and look at the negative likelihood ratio. So there, 1 minus the sensitivity over the specificity gives the sort of rule out zone or exclusion zone, and there that a lower negative likelihood ratio is better. So once again, that sort of defines an area where for the customer of where they're going to be able to solve their problem. If the negative likelihood ratio is less than 0.2, the test is going to perform well enough, or it has the possibility of performing well enough to solve their problem. Okay, so now let's match up capabilities and requirements. So remember our ROC curve that we had. Those are the actual likelihood ratios. So that's the capability of our test. Those zones that I mentioned, sort of the rule-in zone and the rule-out zone, those are determined by the customer of what they need to be able to solve their problem. So if the ROC curve traverses through one of those zones, it could be helpful to the customer. So we see here that the ROC curve traverses through the spin zone. So here we can rule in disease using this test. It's not good enough to rule out disease for this particular case because it doesn't go in the rule out zone. So the key points here is that accuracy is not necessarily equivalent to usefulness. It just depends on the problem that somebody's trying to solve. So it's a relative thing. So the potential usefulness of a test is determined by its likelihood ratio, and those can be described as a function of sensitivity and specificity. And I like to think of usefulness as the capabilities of a test minus the requirements. Don't ask me for the units for that, but you can just think of it as the difference. Can the capability of the test bridge the gap of uncertainty that's required? So the objective here is to either exclude or confirm disease. You start with a prior uncertainty. There's a required level of uncertainty in order to take action, and the impact of a test is the actual likelihood ratio versus the required likelihood ratio that's required and able to solve the problem. So let's look at another thing here. What about setting thresholds? We mentioned that the sensitivity and specificity change as we change the threshold here. So where should we place the threshold? Now, that's a difficult question because you can see there that no matter where we move that threshold, the vertical blue line there, we're going to make mistakes. There's going to be people with disease that we call negative. If we move it to the left, there's people with no disease that we're going to call positive. So we're sort of caught in a bind. There's no between a rock and a hard spot here, and it's not clear where we should put it. Well, one way to think about this is that the ROC curve, if you draw a line from the origin to any point on the ROC curve, the slope of that is the likelihood ratio of the test. So down in the sort of southwest corner there, we have a high positive likelihood ratio. So that's a zone where we can confirm tests. Up in the northeast corner, the zone where we can rule out disease. So there's a relationship there between the set of available likelihood ratios of the actual performance of the test and what we might need. So really, what we need to think about is where we place the threshold. You can see for an ROC curve where that blue dot is. That's just one possibility of all the possibilities that are available to us. We can have any sensitivity and specificity combination that we want that's on that line. And so there's a trade-off then of false negatives and false positives, and basically we have to balance those. So it will differ for different kinds of questions, but I think in general we prefer to have false positives than false negatives. That's not always true. There's certainly harm from false positives. But say like in this case of prostate cancer, I'd probably be more worried about a false negative because somebody goes away, they're out of the healthcare system, the disease could well progress, and then when they come back, it may be incurable at that point. Somebody with a false positive, that's not a good result either, but at least they're in the healthcare system. The false positive will most likely be detected with less harm to the patient than false negatives. So in this case, for this particular test with a PSA, I would want a situation that was less likely to give false negatives than false positives, and I would set the threshold accordingly. So it can sort of be different for different diseases. So let's just imagine here that we want something with high sensitivity if there's, a fairly benign sort of treatment for an easily curable disease, say like, antibiotics for pneumonia. So there you don't want to miss anybody because you're certainly going to be able to treat them, and there's very little harm of giving somebody antibiotics when they don't need them. I mean, that's not completely true. You don't want to be giving antibiotics unnecessarily, but I'd rather give an antibiotic unnecessarily than have a patient die of pneumonia. On the other hand, you have other kinds of diseases that have a pretty awful treatment and with a lot of morbidity and a low chance of cure. And some cancers might be like that. And you wouldn't want to give somebody that kind of treatment unless you were very, very sure that they had the disease. So there you'd want a test that was in the rule-in zone, in the spin zone over there. So sort of there's different zones for thresholds depending on what sort of disease you're looking at, and trading off the false negatives versus false positives. Okay, so just to summarize here about accuracy and so forth. So we have different zones, these rule-out zone and rule-in zone, that are kind of determined by the physician's problem. Are they trying to rule out disease, rule in disease? If they're trying to rule out disease, they need a test that performs up there in the pink zone. If they're trying to rule in disease, they need a test that performs in the green zone. And a test that's up there in the northwest corner where the dot is a very good test that could be used for either purpose. So the key points here about setting thresholds and comparing tests. When we're comparing tests, thresholds are a nuisance, right? Because we don't know that people have necessarily used the same threshold. And the ROC curve and the area under the curve facilitates comparisons of diagnostic accuracy. So that's a good thing. It eliminates the thresholds, which are a nuisance in that setting. But when we use tests, thresholds are absolutely required. We can't use a test unless we define a threshold. And these thresholds can be used to link capabilities and requirements of tests, and they can be set to optimize performance. And the optimum of where you would set the threshold is very context dependent. It depends on the costs of errors, on the relative impact of a false positive or a false negative. And we gave some examples of that, say, of cancer versus pneumonia. So let's go on and look at some other reasons why test results differ. We looked before at thresholds, and that's one reason. But there's other reasons that we can look at. I classify these as true differences. Like a threshold difference would be a true difference, and there's other reasons that could be true differences between tests. And there's sort of false differences, such as bias in a test study, and then finally just random variation or imprecision could give differences in test results. And so let's just look at all of these. So usually when we're evaluating test accuracy, we're comparing a test to some sort of gold standard, and we use what we call the index test. That's the test that we're evaluating, and we compare it to a gold standard. Often when we're evaluating tests, we'll start out under very ideal conditions, okay? So let's say we're studying heart disease. So we use our test and test it on people in the ICU versus marathoners. And hopefully your test can distinguish those two people. If it can't, you've got real problems. But that's a very idealized situation. You should be able to discriminate those. And if your test can't, you've got problems. So that's a legitimate kind of study to do in developing a test, sort of as a first hurdle, but it's not the problem you're going to face clinically, right? So over on the right side, we see a more realistic situation where there's overlap between the two populations, and the test needs to discriminate between them. So where will we get higher specificity and sensitivity? Where will we get better results when we use this test? Well, obviously, in the ideal situation, you're going to get really good test performance, right, compared to the more realistic situation. So the point is, once again, that the performance of a test is really context dependent. It isn't an intrinsic property of the test, the sensitivity and specificity. It depends how it's used, where it's used, and so on. So let's look a little more at that. Okay. So here, if we look at our ROC curve, here's an ideal kind of situation where the There's a big difference between the populations, and your test should be able to tell that apart, and that would be the upper red curve. A more realistic situation is shown below, and on the green line on the ROC curve, and we'd have much worse test performance. So how could this happen? How could we get differences in the populations like this? Well, this could really depend a lot on what we call a referral pattern or disease spectrum. So let's imagine that somebody has chest pain. And there's all different gradations of chest pain, right? Some niggling little stitch that you have, or a slight discomfort or something. And those people might go to the general practitioner or a primary care doctor. It doesn't feel urgent, but they're concerned about it. And so there might be, a fair amount of overlap with people that have disease, and that's given by the red dots there, versus the people that don't have disease. And so the general practitioner is faced with a pretty difficult problem, because the spectrum of disease, people with disease and don't have disease, is very close, because people that are coming to the general practitioner by and large aren't very sick. On the other hand, if somebody has crushing chest pain, shortness of breath, and so forth, they're going to go to the emergency department. And so you're only going to see the people that are at the very end of the spectrum of what you would see at the general practitioner, or probably not even similar to the general practitioner. And they'll be very, very different from the healthy population. So the diagnostic problem for the emergency department, in this case, is much easier than it is for the general practitioner. So a test performed in the emergency department would probably perform much better, say detecting heart disease for this particular instance, than it would in the general practitioner context. So once again, a test is dependent on the context that you perform it. So now let's look at how referral patterns can also affect the population. So let's imagine that there's patients with complaints, and there's some sort of test result that gives these two distributions here. The red ones are the people with disease, and the blue ones are the ones without disease. And you can see down below with a group with the patients with complaint, there's quite a bit of overlap between them, but the sick people tend to be distributed more to the right, and the non-sick people more to the left. Well, people sort of self-diagnose. Some people go get over-the-counter medications, or decide they're healthy, and they'll wait it out, and so forth. So that spectrum changes a bit. Some of the either end of the spectrum goes away, and the general practitioner sees a different probability distribution. And there's much more overlap between the two. So the general practitioner has a harder time making a diagnosis than he would if he just looked at the general population. Now, what happens with the general practitioner picks off the easy cases. He goes, you're obviously well, you're at the left-hand side of the blue dots, and you're obviously sick, you're on the right-hand side of the red dots. You go to the hospital, you guys that are well go home, and what's left over that I can't figure out, I'm going to send to the specialist. So the specialist sees a very narrow distribution with a great deal of overlap. So where is the test, say, that if it's applied in the general practitioner's office versus a specialist's office, where will the test perform better? Well, it'll perform better in the general practitioner's office, because there's more ability to discriminate between the populations. It'll perform poorly in the specialist's office because there's such an overlap between the populations. So once again, the performance of the test is context dependent. What about prior testing? Same sort of thing goes on here. So let's just imagine that we have a patient that has some sort of concern of disease, and say and the doctor becomes concerned about prostate cancer. So they do a digital rectal exam. They do then aren't quite convinced, and they do ultrasound. Some people are diagnosed, sent off for biopsy. There's some that go on to get a PSA test. So every time you do a test and you send people off and make a diagnosis, the spectrum of disease changes. So let's look here about what would happen if we compared the performance of the PSA test, if that was done alone, down on the bottom line, versus the PSA test following all these other tests. Well, what's happening there is the PSA test is being conducted on the two hard problems, where it's probably going to be intermediate. It's going to be difficult. So it's possible that the PSA test in that population would not perform very well because it's a difficult problem there. DRE has failed, ultrasound has failed, and so all these cases have been put in the too hard basket, and we're using the PSA test on a difficult group of patients. Whereas below, there's lots of people that obviously have disease and people obviously that don't have disease, and so those will be probably classified correctly, and the test will look a lot better in that context. So how can we think about differences between tests and so forth? So there's this mnemonic called PICO that talks about ways to think about specifying a test in a study. So the population talks about the setting that it's done in. Is it a primary care physician's office? Is it a specialist's office? What comorbidities are in the population, the referral pattern, what tests have been done beforehand, what doctors have they seen beforehand, exclusion and inclusion criteria for the study. All these can affect, as we've talked about, the performance of a test. And then there's other things, just how the method is done, what cutoff level was done, what's the skill level of the personnel doing the test, are there differences in the way the test is conducted. Then we're looking at the condition or the disease of interest, and there can be all different levels. It can be subtle disease or very profound disease that's relatively easy to detect. And then the comparator. So what are we using as a gold standard? So, and that can change the definition of disease. If we're doing clinical follow-up, that might be a lot less sensitive, for example, than doing an MRI or something. So we would pick up different cases with the gold standard, depending on what gold standard we use, and that would change the performance of a test when we compare it to that different comparator. Then the outcome measure that we look at is important too. So we need to define all of these things when we're talking about a test and we're comparing the performance of a test. All of this needs to be specified because context is everything. Okay, what other things can make differences in test performance? Well, let's talk about bias and how that can come into test studies and how that affects us. So a couple of different sources of bias that are common in diagnostic accuracy studies. First, we can have an imperfect gold standard, and that causes problems, and that's fairly common. That arises because in many cases the gold standard is very expensive or invasive or painful or something like that, and for that reason you can't send people with a negative result to get the gold standard. And so you use a brass standard instead. Another one is verification bias, and there's indeterminate results and so forth. Let me just describe these real quickly. So the imperfect gold standard is called differential verification. So we have patients, they get the index test. Those that are negative, we send to maybe just clinical follow-up, and we watch them to make sure they are negative. That's a different standard than maybe surgery to determine whether a tumor is present or something. So you're going to have different performance depending on, because you're using different standards. And this is a source of problems in diagnostic accuracy studies. Unfortunately, we have to live with it because it would be unethical to send all the negative patients to the gold standard. But we need to be aware of it and correct for it in diagnostic accuracy studies. Another one is verification bias or differential sampling. So in many studies, you see you have the patients, we do the test on them. Those that are positive, almost all of them go get the gold standard, say like surgery or something. Those that are negative, a very small percentage get the gold standard. And this can lead to bias in diagnostic accuracy studies and give very misleading results of sensitivity and specificity. This is very common in areas where the gold standard is invasive or expensive. And then there's another one of bias due to indeterminates. So let's imagine that there's two different people evaluating cases. Evaluator A is very decisive, classifies every single patient that he sees. So this person is going to have low sensitivity and low specificity because they're going to make mistakes, right? There's going to be some that are misclassified. So evaluator B is much more tentative and says, there's just many I don't know. I'm not going to make a diagnosis. So in the upper one, he goes, those that are on the right of the red dots, clearly they have disease. I'll classify them. I feel comfortable. Everybody in the shaded area, I'm going to put in the too hard basket and not make a diagnosis. And then the ones on the left, in the blue dots, those people are clearly well. I'm happy to make a diagnosis there. So this person, because of the way they make diagnoses, is going to get it right most of the time. This is like taking a test where you only answer the questions where you know the answer, whereas the other person had to answer all the questions whether they knew the answer or not. And so how people handle indeterminates and their propensity to use indeterminates will affect their sensitivity and specificity. So where do these values go? When we look at our typical 2x2 matrix, all these ones in gold are the indeterminate values. And depending on how you classify these can really affect your statistics of sensitivity and specificity, right? Some people leave them out. That's one way to handle it. Some people classify them as negative. Some people classify them as positive. And depending on how they do that, they'll get different results for sensitivity and specificity. So you need to be very aware of this, and that can be a reason why published studies give different accuracy results. Then the final thing is just random variation or imprecision in testing. And all studies have some uncertainty in them. So one way to handle that is through meta-analysis, where we combine results from different studies into an overall average. So it's the same basic approach. The biggest, the more samples you take, the less uncertainty there is in the result. Well, every study can't be large, so meta-analysis is a way of combining results from many studies into an overall average. The other thing you can get out of it is looking at, are there differences in the tests? We might look here and go, all of these over on the left-hand side seem to be fairly similar. They're not that different that you would think there's something odd about them. So there's one over here that looks like it's an outlier. Maybe there's something in the PICO group. It was a different population. The test was conducted differently some way. They used a different reference standard, something like that that causes this. So meta-analysis can be a way also to investigate reasons for differences in test performance. So let's just sort of list what we've gone through here of ways that tests can be different and the reasons for it. We can have true differences, okay, that are, and the countermeasures there would be complete reporting, of the PICO values, the population, how the index test was performed, the outcomes and so forth. So we need to be very precise so we understand that. Meta-analysis can also help uncover sources of differences between studies and tests. Then there's false differences that can either be due to bias, due to those things I mentioned like verification bias, differential verification, or how people are handling indeterminates. The threshold problem, a countermeasure is using ROC curves. Bias you can get around by using better study designs. And finally, there's random variation. Once again, that can be helped with study design within an individual study, and then we can group studies together using meta-analysis to help reduce variation. So now let's look at a couple higher levels of test evaluation. So right now we've been looking at clinical performance of how well can a test classify patients and what would be reasons for differences in their ability to classify patients. So we've covered that, I think, pretty well. So the next thing to look at is, even though a test is potentially useful, doesn't mean it's clinically useful. So there's all kinds of problems you can run into in practice. That the test isn't used properly, or the test doesn't change the diagnosis, or the test doesn't change management. So it has no clinical impact, even though it's classifying people correctly. And the other thing is that tests aren't used in isolation, and we really need to understand the incremental value of a test versus the isolated value of the test, so when it's used in context. So the key question is, do patients who receive this test or have this test available have better outcomes than patients that don't? And there's very few trials actually that do that kind of thing. We do tests of accuracy a lot, and it's clinical performance, but we don't look at the clinical effectiveness. First thing is that tests don't exist in isolation, and this is something people call test research versus diagnostic research. So on the bottom, we have some sort of patient with nausea, and we apply the test and determine whether they have a disease or not in isolation. And basically, we're looking like we have before whether you can classify the people based on that test. But in reality, a test is used with many other tests and sources of information. And really to look at whether it helps, we need to look at the incremental value. So given that somebody's already had test A, B, and C, what does this new test add? And there's very few studies of that type. So I think that's an important thing. So when you look at a test in isolation, which is sort of an artificial context, the test could look like it's pretty useful because it's adding a lot of information. But in reality, it may add very little incremental information. And tests are often combined, right? We use a bunch of different tests, and trying to unravel what's the individual contribution of one test, because results can often be correlated. And so the incremental value of the last test can be difficult to determine when you're doing many tests. So the acid test of what we'd really like to know is, here we have all the usual tests that are going on. We add an additional test, and we'd like to see how patient outcomes differ in the upper group than the lower group. But such kinds of studies are rarely done. So let's look at a clinical trial evaluation where somebody actually did do this kind of thing with prostate screening again. So when we look at all-cause mortality, in the screening group, there were 200 deaths per 1,000, and 198 if people were screened for prostate cancer. So very little difference in the death rate there. So we can wonder whether screening is useful. We see there's very little when we look at disease-specific mortality, the actual death related to prostate cancer. Once again, it's a very small difference. And then how many people got a prostate cancer diagnosis? Well, then the screened population is quite a bit higher than in the non-screened population. So we can see that 20 more people are getting a positive diagnosis that due to screening, and we're having one less death. So there's sort of a balance there between it. There's a lot of worry associated with that diagnosis. So you have to wonder whether this is really adding anything or not, whether people are better off as a result of this test. So there's different ways you can evaluate tests too, and I think we can think of this in analogous to therapeutic trials, and those are divided into explanatory trials, and these take a scientific perspective, and they ask, does this drug affect some physiological variable, right? So we have a carefully controlled population, and the drugs are carefully administered. We monitor a bunch of physiological variables, and we see whether the drug affected blood pressure or something like that. In that kind of a trial, we would only count people that actually took the drug, because we're only interested in comparing the effects of people that had the drug versus people that didn't have the drug. So that's what's called an as-treated analysis. But there's also things called pragmatic trials, and this takes more of a policy perspective. And it's not asking what's the effect of this drug on the body, which is what's done in the explanatory trial. Pragmatic trial says, what happens when you prescribe this drug to people? Does it affect outcomes? Well, all kinds of things can happen when you prescribe a drug. People can not take it, they can sell it, they can switch to another drug, some other treatment, and so on. So there, what you're looking happens is, given that I've prescribed this to a patient, do they get better, irrespective of the reason? And there you use an intention to treat analysis, and you count everybody. So you could do the same kind of thing in diagnostics. Usually the case in sort of test evaluation, so we have a single test with an idealized population. We have expert administration of the test, usually at a big research center. We have experts interpreting it and so forth, very idealized kind of conditions, very similar to what an explanatory trial would be like in therapeutics. what we really need more of is pragmatic tests where we're investigating the impact of a test in the context of multiple tests in an actual population, not a idealized population under usual conditions where doctors won't use the test correctly, they won't interpret the test correctly, maybe not maintain the instrument correctly, and things like that. So there's not a lot of research of that type like there is for therapeutics, but it's something that's needed really in test evaluation. So this is a very high level of test evaluation. And then finally, I think at the highest level is cost effectiveness. And we can look here in this graph. We have cost on the vertical axis, effectiveness on the horizontal axis. We usually measure effectiveness in quality life years. So the longer you live, the more quality life years you have, and the healthier you are, the higher quality those quality life years are. So that you get a better score the longer, the healthier you are. So when we look at this plane, there's things that are up in the northwest corner that are high cost and less effective. Those are no-brainers. We don't want to use those. And then at the in the southeast corner, we have things that cost less and are more effective. Those are the things we really want. But most of the time, it's a trade-off where we pay more to get more effectiveness. And that's shown with those two cases up there in the northeast quadrant. And so we can sort of consider trade-offs. So here, with cost effectiveness, we say we have a new cancer drug that costs $100,000 per quality life year, say, relative to some comparator. And then we have a diagnostic test that maybe costs $10,000 for quality life year. So here, when we make comparisons, we're almost able to compare apples and oranges and go, what would we spend our money on? Given we have a limited healthcare budget, looks like I'm getting more value for money for the diagnostic test than the new cancer drug. So, if my budget was limited, I would spend more money on things that have a lower cost effectiveness ratio of, say, $10,000 per quality life year than $100,000 per quality life year. So this is a typical sort of way that health economists would look at diagnostic tests. So the summary here is we have many ways to assess test performance. And there's many reasons why tests differ. We talked about those. There's real differences when we look across the different PICO items, the population, the way the test is conducted, so forth. There's false differences between tests that can be due to thresholds or bias, and there's just plain old statistical variation. And there's a lot of progress, I think, in performance evaluation of diagnostic tests. The quality of reporting is getting better. So you can actually identify if there's real differences between the ways tests are performed. The quality of the studies is getting better, so there's less bias of studies. And I think there's getting newer types of studies like cost-effectiveness studies, pragmatic trials, and things like this. And I think all this is improving due to education of clinicians and laboratorians. So anyway, I think you can appreciate that there's a lot that goes into evaluating a test besides simple sensitivity and specificity, and I hope this has been useful for you. Thank you very much.